and then we'll start. Okay, so it's streaming now on YouTube. Okay. I'm just trying to get the okay from Diana, and then we'll go ahead and get started. Okay, perfect. All right. Hello, everyone. Thank you for joining us today in our webinar about tobacco-related substances. We will begin this event with a short introduction on Shifa Community Clinic and our first guest speakers for today. For those of you who do not know, Shifa Community Clinic is one of the UC Davis's 7 student-run clinics that provide health services to the underserved and uninsured population of the Sacramento area. Our speakers for today is Dr. Tung. Dr. Tung is an MD, MA, is an associate professor of internal medicine at UC Davis. For over 20 years, she has worked on tobacco control policy and cessation issues with a special interest in addressing health disparities. And Dr. Mukherjee is a DRPH and PH, is an associate professor at and an incoming chair of the Department of Health Sciences at California State University, East Bay. Dr. Mukherjee's research has focused on the intersections of culture and behavior among Asian American populations, particularly in the South Asia community, and their effects on health disparities in these understudied groups. They will be giving more perspective on tobacco, how tobacco can affect our health and environment. And I'll give the floor to Dr. Tung.
Great. Well, thank you very much. It's an honor to speak here today. Let me just pull up my slides and see if it goes to slideshow. Mm-hmm. All right. So today, I'm very happy to speak on tobacco or health, and I'll just do a broader introduction about smoking, vaping, and quitting, which is generally what we know, at least for healthcare providers or the community. Where are things now? But I'm really excited for my colleague, Dr. Mukherjee, to also talk to us about South Asian cultural tobacco products, because that is something that we do not generally have a chance to learn about or talk about. And so we hope that this will help stimulate some discussion afterwards. So let me just explain a little bit about smoking. It's been over 50 years since we've known that smoking causes cancer. In the 50s and beforehand, the tobacco industry would even market that doctors would endorse smoking for certain reasons. They had the original Mad Men, which is a TV show. But it's as the science was accumulating in the 1960s, the Surgeon General issued the first report saying that smoking causes lung cancer, and this was from biological and epidemiological evidence. So we've known that for quite some time. And then with the growing evidence, we've known that smoking is the leading preventable cause of death and disease. And so there's more than 480,000 US deaths annually from cigarette smoking. And just to put that in perspective, the deaths that we've had from the COVID epidemic in the US has been over 500,000 this past year. So we know that lung cancer is one that people often think about, but heart disease is actually the leading cause nationwide. And then we have lung disease like COPD, stroke, and other cancers that also contribute to these annual deaths. And then on the figure to the right, we know that smoking causes 12 types of cancers. And in the past decade, liver and colorectal were added on here as well. And then there's a whole host of chronic diseases, some of which are heart and lung, but the things that may surprise you, that smoking causes diabetes, reproductive health problems, lung infection problems and COVID. It worsens COVID-19, although there's probably still evidence that we need to look at for understanding how it relates to developing infection, but it can make you sicker or die from COVID. And then also immune function. So smoking also causes diseases like rheumatoid arthritis. And then secondhand smoke also harms non-smokers, which has driven a lot of public health policy, why we have a lot of smoke-free laws today. So what is secondhand smoke? It's the smoke that comes out from the end of a burning cigarette or from a smoker's mouth. There's a term called third-hand smoke, which is the residue that accumulates on people's clothes or carpets. And it continues off-gassing, and all those chemicals, those thousands of chemicals, keep reacting. That's why it becomes so toxic. And toxic, especially to children who have small lungs. And you can see this list here below that secondhand smoke causes sudden infant death syndrome, respiratory infections, asthma attacks, ear infections in kids. And then it's also for adults. We have to still worry about heart disease, stroke, and cancer, and cardiovascular disease and pulmonary disease. It's because if you think those little particles causing inflammation, that's the mechanism where we get this sort of tobacco-related disease. So for over 30 years, we've been fortunate living here in California that we've had one of the first statewide tobacco control programs. And over these 30 plus years, we've seen that the smoking rates in California has gone down a lot faster than the US. And in this graph you can see the California lines, the blue line, and the gold line is the rest of the United States. However, we know there's still a lot of disparities in tobacco use. Depends on where you live, who you are, what else you have going on personally. So there's a lot of different factors, and we know with California being such a large, diverse state, that we still have a lot to do in terms of reaching different communities. Just want to say globally that there is a lot of efforts for tobacco control, and the World Health Organization has something called the Framework Convention on Tobacco Control, which in 2003 was the first international public health treaty for countries to sign on, for governments to enact best practices for tobacco control, very similar to what the California Tobacco Control Program has been doing in terms of monitoring tobacco use, smoke-free laws, offering help to quit, educating with media campaigns or graphic warnings, also bans on advertising, reducing the supply that's available, and also raising taxes on tobacco, which is very motivational for people also to quit. So what else has gone on in the US since then is the Food and Drug Administration in 2009, after many lawsuits with the tobacco companies where they acknowledged that there was a lot going behind some of their with their lawyers and the closed doors. There were lots of lawsuits where some of this evidence came to light about how they were manipulating nicotine to addict people, and also at the same time trying to subvert some of the scientific evidence and conclusions that smoking causes disease. So this is why in 2009, the FDA has the authority to regulate the manufacture, distribution, and marketing of tobacco products. And approval is needed to market, make cessation or reduced harm claims. At the same time, as many of us know, at the nationwide federal level, regulation is very slow. Things take a lot of time. And this is where the tobacco industry may be able to exert maybe more influence, so you don't see things happening as fast. And you may have heard about the FDA making a ruling lately about banning menthol from cigarettes, and that's because in 2009 they banned flavors except for menthol because the tobacco industry said it was important for a characterizing flavor. But in the meantime, since then, we've seen a lot of different products developed that are not cigarettes. Cigarillos, you put a brown piece of paper on it and you can call it a cigarillo. Little cigars, electronic cigarettes or e-cigarettes, and these don't fall onto this category of the rules for cigarettes. And I think this is also important for our talk today about South Asian cultural tobacco products. So what is an e-cigarette? Just a little bit about vaping. They come in many shapes and sizes now. A technical term for them is, you might hear, is electronic nicotine delivery systems. And what they do is they heat a liquid to produce an aerosol that users inhale. And people put not just nicotine or flavors in them, but they may also put THC or CBD, which are related to marijuana. So people are using multiple substances in here now. And what's in the aerosol? There's an early misconception that it's just water vapor, and it's not. This is a CDC infographic that just demonstrates some of those chemicals and particles that are found in e-cigarette aerosol. Even if they have less cancer-causing chemicals, that still doesn't make it a safe product. Because these devices have lithium batteries, there's also heavy metals such as nickel, tin, and lead. And we're finding that the flavors themselves have health effects that are very important for the heart and lungs or immune function. And even if things say that they're nicotine-free, they're not regulated at the point where that's a sure thing right now, because regulation and some of these disclosures to the FDA, that's such a very long process that's taking years. So for right now, what I would tell patients is, it's sort of buyer beware of, you're just trusting what's on the labels right now. And there's a new technology here for these devices called nicotine salts. So nicotine, we already know, is one of the most addictive substances, even more so than the so-called hard drugs. And where we now see that not just the cigarette is addictive, but they've made it even more addictive with chemically. So you might have heard that there's one pod of liquid, which people use in these flash drive devices, such as Juul or Puff Bar, that the amount of nicotine in there is equivalent to at least one pack of 20 regular cigarettes. And that is actually very shocking to a lot of people. But the reason why that people can use it like this is also because the industry has lowered the pH level in these nicotine salts such that you can absorb a lot more higher levels of nicotine and not get the same sort of effects that you might from smoking one cigarette. So you don't feel like throwing up, you're not nauseated. And this is actually very concerning because the Surgeon General has also warned that especially for young adults, people who are where we know that are using and are attracted to these devices, the brain is still developing up through age 25. And so if nicotine is also not just an addictive substance, but it's also used as a pesticide, there are actual health implications that it'll take us many years to understand, how it's chemically changed and altering our human health. So you may have heard there's been vaping is a youth epidemic now, and in 2017 to 2018, they saw an 80% increase in e-cigarette usage by high school students, and 1 in 4 high school students have ever used a tobacco product, most of them flavors, and as young as 12. And there's now evidence, Dr. John Pierce at UC San Diego did a longitudinal study analysis that showed that kids who vape are 3 times more likely to become daily regular cigarette users as well. So we've also heard, if you know of kids in high schools, that the bathrooms became vape rooms, and it became rampant. And it's taken a while, but the California Department of Education, they do fund the school districts to do tobacco use prevention and education programs. So I think this past year, they've been able to start using an approved curriculum from the Stanford Toolkit for vaping. So although this epidemic has gone on for several years, our kids are finally getting some structured education about vaping and the industry and what these devices do to you. So we know besides nicotine salts, the flavors are very attractive. And why is that? It's because it's candy flavored, it's fruit flavored, it's mint flavored, it's funny name flavored like unicorn poop. So it's a kid-friendly menu. And this is just a graph showing in the gold that of all these devices that kids use in California, the majority of them are flavors. And so that's something we need to be aware about. And then in the midst of this, after the youth epidemic started, then we had the EVALI epidemic right before the COVID pandemic hit. And that was almost 3,000 hospitalized cases or deaths nationwide. And it was mostly young people that were getting sick. The median age was 24 years, as young as 13, going to the hospital. And this is just the race ethnic background that from some of the cases that were described. And people actually died from this. There were almost 70 deaths confirmed in 29 states. The median age was a little bit higher, almost 50 years. And you can imagine that's because people may already have some other health conditions going on. What were people using? Not just nicotine. They were over half of them where they were able to interview folks said they were using THC, which is the psychoactive marijuana component, and nicotine. This is a very hard diagnosis to make. If you look at the CDC little graphic on the right, it's very vague how people might present. Even though it's called e-cigarette vaping product associated lung injury, it's just like COVID. You don't necessarily start with lung problems. You might just feel tired or fatigued. You may actually start off with having nausea, vomiting, or diarrhea. And then when people get sick enough and they can't breathe, and then they get an x-ray, that's when they see, that there's a wide spectrum of lung injury that goes on. And it's what's called a diagnosis of exclusion. You have to rule out all sorts of other infections first before you make this diagnosis. You have to take a careful history of even the past 3 months of what have people been vaping. And as you can imagine, if you're a teenager, you may not want to admit that you're vaping, or you may be in a state which doesn't have recreational marijuana legalized. So this can be a very challenging diagnosis to make. And even in the time of COVID, we're still seeing EVALI. So even though the CDC has stopped tracking it officially on their website, it's still something that we all need to be aware about and make sure we ask people very carefully about what are the products they're using. And you may want to know how this has turned out if flavored tobacco products that has been such an issue. What have states been doing about it? So in California, actually Governor Newsom last year signed a landmark bill to end the retail sale of flavored tobacco products. And that was supposed to go into effect in January of this year. But just for educational purposes, I'm just sharing with you that the tobacco industry issued a referendum, which has delayed the implementation of this law. And so it's not going to be on the governor's ballot not on the ballot for the referendum with Governor Newsom this November, but it's going to, what I've heard is it's going to be on the ballot for next year. So this is something also to know about and be mindful of when it comes to a vote next year. In the meantime, there are still local counties and cities that are passing their own laws. And again, it's just at the local level, a lot more things can happen faster than at the state or federal level. So finally, let me just transition to how to help and support someone to quit. And if you know someone who's a tobacco user, it's very important to be empathetic and to listen to them and be supportive of them. It takes multiple tries to quit for good. In fact, tobacco is considered sort of a chronic disease because it is one of the most highly addictive substances, and it can take at least over a dozen tries before someone quits for good. And so whether you're someone who's a friend or family member of somebody who uses tobacco, or if you're from a community organization or a healthcare provider, if you're working at Shifa Clinic, this is some good basics just to know about so that you can offer resources and support somebody. So what happens when you quit smoking? There are immediate health benefits. And this is just an infographic from smokefree.gov that shows even within minutes, your heart and lung health gets better. And within a couple weeks, your lung function begins to improve. And within 1 year, your risk of heart disease is half of that of a smoker. And then it takes several more years after that to reduce your cancer risk. But the longer that you've quit and stayed off cigarettes, the better. And now, just to mention, there is something for lung cancer screening now for people who have ever smoked. So it's for now, they've just updated the guidelines this year for people 50 and up to be able to get annual low dose CT scans to screen for lung cancer. And this is something also where you have to not just be age eligible, but also how much you smoke and when you've quit. So there's something pack pack years. So if you smoked 1 pack a day for 20 years, that's 20 pack years. They just lowered that threshold this year too. And then if you've quit smoking, you've had to have quit within the past 15 years. So this is, again, it's not just about helping someone to quit smoking, it's also helping them to maintain their health if they've been a heavy smoker. Just briefly, there are tobacco cessation guidelines, and what we know is considered best evidence-based practices are that counseling plus medications can support somebody to double their likelihood of staying quit. So what is counseling? It comes in many forms now, whether it's in a group setting or telephone. There are free quit lines in every state. There are online programs, there's chat, there's apps. And then medication-wise, there's 7 medications that are approved by the Food and Drug Administration for smoking cessation. So there's 5 nicotine medications. You may have heard of nicotine patch, lozenge, and gum. Those are over the counter. There's also nasal spray and an inhaler, which is not like an asthma inhaler, it's more like an inhalant. And then there's 2 pills, bupropion and varenicline. And then if you use over-the-counter nicotine patch, you should also consider gum or lozenge for an as-needed basis too. That's called combination therapy, and that's considered even more effective to help. And this is just to remind me that the U.S. Preventive Services Task Force, which comes up with clinical guidelines that the insurance plans also go by, they said there is insufficient evidence for electronic cigarettes to be considered a smoking cessation, and the FDA has not approved any of the e-cigarettes for smoking cessation. Just a word about free quit lines. The California Smokers Helpline, which is operated down at UC San Diego, they offer free expert help. They've been around for over 30 years. If you may have known them as 1-800-NO-BUTS. They're going to rebrand in September to Kick It California, because they don't just help smokers now, they also help with people to quit vaping. And it's for 13 and up. You don't need the parents' permission. They do have a text program. They have an app. So you can go to their website to look for more information. A lot of people don't know what a quit line does, and what does the counselor do? They help a client talk through a quit plan. They help with motivation, confidence, skills, self-image, perseverance. There's also been free nicotine patch offers where they'll mail home 2 weeks of nicotine patches to eligible smokers to get them started. So then they can go on and get medication from their provider or from the store. And this is just a sample of their protocol, what they do on their intake to get information about who they are, setting up a 25 to 30-minute one-to-one free counseling call to set a quit date, and then help with follow-up for several calls afterwards. So this is my last slide. My California Quits project, what we do is we have been trying to help safety net clinics and health systems and work with Medi-Cal managed care plans and public health partners to try to help with systems change. And part of this is just getting clinics also to ask, advise, and refer systematically for resources. So we now need to know, we can't just ask, do you smoke? Because that's not enough anymore. We have to ask about all different tobacco products. And maybe for SHFA Clinic, it's important also to make sure this is part of the protocol to include cultural products as well. And if someone does use vapes, you need to also ask about what are you using, nicotine, marijuana, or both. As seen by the EVALI epidemic, we now need to know what people are using, have something ready to go to say to advise them about stopping use or exposure, and then referring them to support, whether that's within your own clinic or also to something like a free quit line. So I will pause there and we can transition to the next talk.
Thank you, Dr. Tong. and I am very honored to be with all of you today. I do want to also recognize that Dr. Tong is not only a national expert on this matter, but a very dear and valued mentor of mine. So I wanted to thank her in a public setting for all of her guidance in my own development. So in any case, I think Dr. Tong has given a wonderful overview of how far we have come in tobacco control, but also how far we need to go. And I know the COVID pandemic has taken us away from much of the things that we struggled with in terms of not only preventable chronic disease, but also disparities among groups of folks. And so to that extent, given that SHIFA provides such an important community service to both the South Asian and Middle Eastern populations in the greater Sacramento area, it's important that folks who are interested not only in this topical area, but also in these populations, recognize that there is a behavioral risk factor profile that often goes under the radar, both in terms of research and practice, but also at a community level. Often much of the use of some of these products that I'm going to discuss are not seen quite as harmful, but rather part of embedded in cultural norms and behaviors. So as Noor mentioned, my name is Arnab Mukherjee. I'm the department chair and associate professor at California State University East Bay in the Department of Public Health. And what I will be discussing is the cultural context of tobacco use among South Asians. So where do we start? Well, I mean, South Asians, and I want to underscore, I didn't put slides on this because that would be half an hour in and of itself, but South Asians are folks that have origins in the Indian subcontinent. So India, Pakistan, Bangladesh, Sri Lanka, Nepal, etc. It is important to underscore two things. Number one, South Asians are not simply Indians. And number two, South Asians are not a model minority. There's a visible segment of the population which tends to have socioeconomic advantage through education, employment, etc. But there's also an invisible part of the population, probably those who are seen by Shifa Community Clinic, who experience considerable social and economic disadvantage. And we need to recognize that those members are part of our community and require the attention and services that are afforded to other groups. So I also want to include, on behalf of many of my students, that South Asians are not only direct migrants from South Asia, but particularly in California, there is intermediary migration. So there's a lot of Indo-Fijians, for instance, in California. In New York and New Jersey, there's a lot of Indo-Caribbean folks. So those are also members of the South Asian community. And I function under the worldview that the South Asian demographic identifier is more inclusive than it is exclusive. So to that extent, the way to start, at least in my nature of inquiry, is, okay, what is going on in the native subcontinent, in the region of origin? And some of these slides are dated. As you can imagine, it is difficult to find sort of information in one place. But I would venture to guess that these numbers probably have not changed or changed significantly in the last decade. But if you look at the slide on your, if you look at the table on your left, what you see is, number one, that each of these countries of origin have a considerably different profile. Most importantly, you see that smoking, so when we're talking about the use of combustible products, primarily cigarettes, but arguably things like bidis and hookah, is largely a male-driven behavior. You can see that under the blue bars in each of the countries of origin. However, if you look at the table on your right, you see that when we look at smokeless tobacco, number one, you see that the differences between genders are not very different. And in fact, in Bangladesh, when we have credible data, you see that the female prevalence is actually higher than the male prevalence in Bangladesh. But nonetheless, across both males and females, the current use prevalence is high. And among youth, depending on country of origin, there's not only tremendous heterogeneity, but if you look at a place like Nepal, for instance, up to 20% of Nepalese males are using smokeless tobacco. So we'll talk about what those definitions are in a second, but again, this is sort of the general backdrop. This is a very busy slide. I will just point you to some data, and for those of you that choose to look at this in more detail, you can. Number one, this looks at tobacco use in Bangladesh, India, and Pakistan, sort of the three biggest South Asian countries. A few things, you see that for smokers, so for instance, current tobacco smoker, you see that the percentages are concerning, but not so much as you see in other places. It's largely a male-dominated behavior. So when you look at smoking, current tobacco smoker, 1/3 of men in India, almost 1/5 of, I'm sorry, in Bangladesh, 1/5 of men in India, and about 10% in Pakistan, current tobacco smoker. But you see a significant burden of smokeless tobacco use. That's among men. Among women, however, you see that current tobacco smoking is pretty low, negligible. Smokeless use, however, in Bangladesh, 1/4 of women are current smokeless tobacco users, 13% of women in India, and it looks like still about 3-4% in Pakistan. So what I want to underscore here is that the traditional understanding of tobacco use among Asians and Asian Americans is that it's a male-dominated behavior. And what I hope to put out there is that when we start looking at other products, and you'll see an emphasis on smokeless, you see that women carry a high burden of the tobacco use profile there. And in fact, if you look, I'm just picking one data point, among all tobacco users in Bangladesh, tobacco using women, 98% of those group is in the smokeless form. So you can see that where the burden is driven depending on country. And just to make it a little bit more interesting, for lack of a better word, even among smokeless tobacco use, and you'll notice that in Bangladesh, just look at the blue part of the pie, the most popular or most common product use is different across all three countries. So to assume that smokeless tobacco is one thing, you can see that is actually not. So it is important to understand these distinctions. Now, of course, I'm looking at data here in the native subcontinent, but like with many of our behaviors, we carry those behaviors into our next point of migration. So we want to also understand that there are very much distinctions in choice of products and product use prevalence. The best data, I would argue, that on a meaningful level that comes out of a non-South Asian country is in England. So in the UK, and again, I picked this graph not because it's the most timely, but it sort of has everything in one place. And what you'll note here is that that same smokeless use burden. So the dark green is using chewing tobacco but does not smoke cigarettes. Depending on what you're looking at, with very rare exceptions, the preponderance of tobacco use, even among migrants, is in the smokeless form. Now, I'm going to start dropping a little bit of vernacular here. When we talk about smokeless tobacco, we are not talking about what you see sort of in mainstream United States portrayals. So we're not talking about Skoal or Copenhagen or rodeo tobacco or those things that come in pouches. We're talking about cultural tobacco products. These are products that have some penetration in the Indian subcontinent, including all those countries that I talked about. They're highly popular. They often don't carry the stigma of regular cigarettes. And nonetheless, they carry, Dr. Tong talked about the chemical composition of e-cigarettes. Some of these products have very much the same level of carcinogenic materials in them. I put one little article on the right that basically, 3,000 chemicals ranging from toxic metals, many of the same ones that Dr. Tong mentioned, arsenic, nickel, and cadmium. And it is responsible for many of the diseases that we see that happen disproportionately among our South Asian populations, both globally and the United States. The use of chewing tobacco is not prevalent just in villages, but it's spreading to urban areas and among the educated with convenient packaging and advertising. It is something that sort of does not fall within the traditional way we view tobacco in the Western world. I want to say about 10 years ago, the CDC commissioned what's called the Adult Tobacco Survey. And it did a few things. It was focused on a whole bunch of different products, not South Asian cultural products, but at least it had a number of different products that they asked about. And most importantly, they disaggregated Asian American subgroups. And one thing that folks like Dr. Tong and I highly advocate for, and this largely has to happen with community input and emphasis, is making sure that when possible to disaggregate the Asian American subgroup. And that argument can be made for the Pacific Islander community as well as other communities of color. But this, we did an analysis of the study, and we looked, among cigarette smoking and smokeless use, because I brought up smokeless use over and over again. And you see that among Asian Indians, they didn't collect data on other South Asian groups, but among Asian Indians, the current smoking prevalence was about 5%, which is really good, relatively speaking. It was particularly a male-driven behavior, 10% for men, less than 1% for women. And you could say, well, we looked at the smokeless current use, and guess what? They don't do a lot of it. This must not be a problem in the United States. And that leads folks to make various conclusions, like tobacco use is generally low among the South Asian, among men, and almost unheard among South Asian women. When people are doing things like trying to figure out what is the independent contribution of tobacco to the disparities that we see that, oh, it's marginal, it's little. But this is based on an understanding that we are using Western measures of tobacco use. But for the most part, it is not Western tobacco that South Asians use. There is a whole panoply of products. Most folks have heard of hookah, because hookah has one of these things that are generationally popular. And that's a story for another day, especially in the current tobacco control world. Bidis were something that were popular in the 80s and 90s, largely because they were seen as this exotic herbal cigarette. Interestingly enough, in India, bidis are actually seen as the poor man's cigarette. So it's interesting how something that was the bottom of the rung of combustible tobacco products became something of high commodity. And among the smokeless products, you can see there's a huge array of things. I will only pick out a few of them because each of these have their own unique compositions. In India and other parts of South Asia, there is a common homemade product called pan. Pan is a betel leaf, and in that betel leaf is a whole bunch of spices. As Dr. Tong mentioned, buyer beware, you don't know what's in any of these spices. So many people say, oh, I chew a pan without this or that. Unless you can tell at the manufacturing what each of these grains are, you actually don't know what's in there. But stereotypically, these are a number of spices, including betel nut, and betel nut is known colloquially as supari. I would just want to emphasize that betel nut is a carcinogen in and of itself, comparable to tobacco use when consumed by the oral cavity. So the notion somehow that I chew pan without tobacco, it gives people cognitive comfort, but it doesn't give you any health benefit per se. This betel leaf is packed with spices. I'm picking supari, often tobacco. It's sealed with a lime paste, and it's usually distributed at cultural events, particularly weddings, celebrations, etc. Again, when you pick this up in a folded leaf and you chew it, you have no idea what's in it. So the notion somehow that there is any consumer control over this is arguable. Now, whenever you have any use of products, there is a commercial interest. So people took this homemade product and they manufactured it into packets. So pan masala is sort of the manufactured equivalent of that. They claim that there is no tobacco in it, but it does again have supari in it. There was a study done in India where they randomly sampled tobacco-free pan masalas and found I think something like 60% of them had nicotine in them. So the question is, where did the nicotine come from? You can probably connect the dots there. There are more explicit forms of tobacco-containing smokeless products, gutka, zarda, etc. And so these are, if you go to any ethnic enclave, I live in the San Francisco Bay Area, if you go to Fremont and Sunnyvale, you can go into your local grocery store and see this blue bottle from a mile away. It's not locked behind a shelf, it's not behind the counter, it is there with the rest of the spices, and that shows that the symbolic sort of lack of harm attributed to these products. Again, we could spend 15 minutes just talking about attributable risk. I hope that you can trust that the use of these products with or without tobacco is responsible for a number of the disparities that we see, particularly cardiovascular and cerebrovascular risk and malignancies of the oral cavity. In India and the native subcontinent, oral cancer is the primary driver of cancer burden, in Asia for that matter. So what do we know about South Asian tobacco use in the US? Well, not much, sadly. But what we can piece together is that when we look at cigarette smoking, as I mentioned in that national study, we know that depending on what study you look at that's representative, you see that cigarette smoking prevalence is pretty low. However, smokeless tobacco rates are largely unexamined. And even when they're examined, the question becomes, are they using the right measures? So when in California or in the Northeast United States or in New Jersey, there have been a number of largely convenience samples, and they found low rates of use, but they used the term smokeless tobacco. They didn't use the term pan masala, or gutka. So at a cultural level, when somebody says to me smokeless tobacco, often people don't think about the products that they actually use within a cultural context. And Dr. Tong discussed the California Quit Line, and I think through my communications with the California Quit Line, there's a low volume of South Asian callers. And I wonder if that is because really there's no smokers, or really is the Quit Line not appropriate per se for the cultural use profile that South Asians exhibit. About 5 or 6 years ago, Dr. Tong and I and another colleague, we published a secondary data analysis looking at the only statewide tobacco use survey that examined cultural tobacco product use among Asian Indians. And what we found, and I'll come back to that in a second, was that the use rate was concerning. Now, you saw that the smoking prevalence, I believe right now in California, is about 10%, roughly speaking. As of 10 years ago, the current use of tobacco products was about 13 to 14% in this sample. Convenience samples in New York and LA have found a much higher rate. Now, they are convenience samples, so you have to take that with caution. And you see among certain subgroups, again, with the caution that it's a convenience sample, among Nepalis, this was very consistent with what we saw in the global work. Almost half of Nepalis were using smokeless tobacco in cultural form. Of the few studies that actually looked at availability and accessibility in Richmond, Virginia, they found that these products were largely inexpensive, 50 cents to $5 a unit, and the warning labels are not aligned with US requirements. In other words, when you buy tobacco from whatever, 7-Eleven, it has to have evidence of the US-based tobacco use warnings, and I believe now they have to take up a certain amount of surface area, and they have to show proof of tobacco tax. That tax was paid on these products. Those are not there on these products. So that begs the question, how are these products getting here? So in addition to sort of what we know on a limited basis, what we do know is that interventions are very much lacking. We know that of a study in Los Angeles that they're increasing provider knowledge and motivation for when physicians are provided with the understanding that you shouldn't just ask about smoking, as Dr. Tong mentioned, you need to ask about other products. Motivation increases among doctors to actually ask about non-cigarette products. When you use sort of community-based outreach, which is not punitive for retailers, there's increased compliance with youth access laws. But the influences on cultural tobacco use are unique. Because this is sort of something that is very much acceptable within a cultural lens, oftentimes the expression of cultural identity is done through behavior. This is a particularly unique South Asian behavior. So the initiation in US, I always found it fascinating that many of my fellow students when I was in undergraduate school used these products, but they had never gone back to India in their lives. But this was seen as a very cultural thing to do. So social norms in the US tend to modify behavior, but not too much. There is a lack of cultural messaging, and there are some, not barriers, but counter drivers that not only are these products seen as not harmful, but in fact, in certain contexts, they're seen as beneficial for health. And as I mentioned, these often formulate maintenance of tradition and expression of identity. Returning back to the study that I referred to, we found that the current use of this is current use, not ever use, current use of culturally specific tobacco use was higher among among Asian Indians, 13% versus 5%. The disparities by gender were very narrow. Both men and women were above 10%. You see 15 versus 12. To the extent that we could look at differences by religion, Hindus and Muslims were much higher than Sikhs. That's not surprising given Sikh prohibition on tobacco. But I think the most, for lack of a better word, fascinating thing about this is that the odds of current use increased among those who had higher education, incomes above 100,000, and immigrants who had lived at least a quarter of their life in the US. This goes counter to the traditional pattern you hear about smoking, which happens largely among low socioeconomic status, low education, and particularly for immigrants, people who have not been here for a while. So that begs the question, with this non-traditional pattern, what would interventions look like? So here is sort of a repository of things I found across the globe. First and foremost, we need to acknowledge that there are alternate uses of tobacco in the South Asian community. So the educational approaches have to be culturally appropriate, both in terms of things like language, pamphlets, websites, etc., but also the quit line, at the very least, need to be, I would argue, in language for certain South Asian subgroups. And I think often that these products are brought in through illicit means. Retailers need to be aware of what they're doing and how they're basically helping foster an adverse behavioral health profile. I think media, especially now in sort of both the Facebook world and also the fact that things like Bollywood have become very global in their reach. I think the PSAs, the public service announcements, health interviews, news articles, not only need to give education, but also need to galvanize sort of cultural leaders, religious leaders in that form to carry the message across. Something that might be of value for folks that are Shifa, we need to really raise awareness among providers with large South Asian populations. I think this is sort of the key thing here. We need to screen for all forms of tobacco use, not only in the clinical encounter, but also in places like community health fairs, which is going to be big given the vaccination push. Can we link something like vaccination or COVID testing with some basic screening and basic advice to quit? As profoundly as we tell people to quit smoking, we need to encourage quitting for cultural tobacco products. Above and beyond that, can we adopt patterns that we know work in communities of color and priority populations? The community health worker and navigator model is one that has shown great success in other behavioral risks. And similar to what Dr. Tong mentioned about support groups and those types of things, can we build those infrastructure up? And I would argue there was something that happened about 20 years ago that I thought was fascinating. Amitabh Bachchan, who is a huge Bollywood icon, and Aishwarya Rai, who turned out to be his daughter-in-law later on, they did a 3-second clip in India to get screened for TB, tuberculosis, and it increased TB screening something like 200%. 3-second clip. Can we do that same thing to get folks to stop using tobacco? I think for folks like myself and other academics, we really need to use the lever of science to really keep this agenda going. So when FDA is talking about like removing menthol and flavorings, we need to make sure that these products, and this is probably true for other communities, are included, because what's going to happen is you're going to have mainstream tobacco control policy that is going to escape broader forms of regulation. To the extent possible, we have existing laws that are not being enforced, sale to minors, as I mentioned, the warning labels that have to be the right warning labels, and the evidence of excise and import taxes. And as I mentioned, we need to have inclusion of culturally specific products, excuse a typo, in the FDA regulatory screen. For those of us that are South Asian, we have the hard job of figuring out how do we de-link culture from behavior. This is a hard thing to do. So what have we learned from changing, for instance, dietary practices, right? Because diet is equally important to culture. How do we frame tobacco use as a family risk versus an individual risk, right? So we have seen, particularly among Asian Americans, like interventions that are family unit interventions, not individual ones, have great efficacy. And we need to figure out in a meaningful way, what is the role of harm reduction? We do have significant problems with people continuing to use products when we promote some form of modified or limited use. What harm reduction might look like in this context, I don't know. But we do know, looking at the last bullet point, that the industry is eager. Think about this, we're talking about billions of people. This is a market that is untapped. So as we are seeing right now with the hookah exemption in local government, where hookah retailers are saying, you are disrespecting our culture by not letting us sell flavored hookah tobacco. We have to be wary and alert about corporate interests and how they might galvanize these things. So there's a lot of work to be done here. I know we've been sort of COVIDing along for the last 15 months. That doesn't mean these issues went away, but I think as we recover and come on the other side of the COVID pandemic, we really need to make sure that sort of an equity lens is put onto our communities, because South Asians, like many other Asian American subgroups, are often left forgotten when we talk about health equity and reduction of disparities. So with that, that was just meant to give you a flavor, no pun intended, of the things that need to be done. And I think Dr. Tong and I welcome any questions or comments that anyone may have. Thank you.
Thank you, Dr. Mukherjee and Dr. Tong for the wonderful presentation. And now we'll be taking comments and questions. And the first question in the chat is, due to these pan masalas being of a great risk, then their positioning on the store suggests and leads to a false narrative of safety that suggests, do you have for any changing this?
I'm sorry, can you repeat that last?
Yeah, I can repeat it. Yeah. So due to these pan masalas being of a greater risk than their positioning on their stores suggests and leads to a false narrative of safety, what suggestions do you have for changing this?
Well, that's a loaded question. So my response would be twofold. I believe that South Asians, like other Asian American groups, are a collectivist culture in which the family and the community come before the individual. I think often retailers don't recognize the harm that they're perpetuating when these products are sold, particularly to people who are underage and other folks. So I think to that extent, I think before we galvanize the lever of policy, many public health folks go straight to policy. And I think there is a very important role for policy, but I think community education and community sort of autonomy comes first. I really think that a lot of these retailers, because of thought processes that they bring back from the native subcontinent, simply think of this as candy. I'm bringing back candy from the native subland and I'm selling it, right? And I think it's not that simple. On the other hand, I think it's important for our local tobacco control folks to enforce the laws that are on the books. That many of these things, whether they be pan masala, whether they be gutka, many of these things that have high levels of harm need to exist within the current regulatory framework. And I think from the policy level, even in the Bay Area, where we have a lot of South Asians, people are simply just not aware that we're talking about these things. They themselves could go into a store and not recognize the blue bottle as something that requires some attention. So I think it has to be a multi-pronged effort, just like any public health intervention. I don't know if Dr. Tong has anything to add, but that would be my thought on the matter.
I think that's very well said. I think my question back to you is, as we need to educate the community and the providers, how do we talk about it? Or, I mean, even the community may not recognize it as a tobacco product when we ask, do you use tobacco products? Or do you have to specifically list the whole plethora of different products before someone says, yes, that one?
Yeah, I mean that's a good question. I think when you say the word pan or you say the word gutka, it connotates as a group of products, right? So somebody who wants to really answer no to the question would be like, I don't use any of those 5. I use this one obscure product, you know. I think even starting the communication with an acknowledgement that we are asking about cultural products and using some of the nomenclature instead of just saying smokeless tobacco, because that they don't equate the two. I think is a starting point. Is it an ending point? I don't know. And a lot of people will say, well, I only use it when wedding. So that, you know, it can't simply be, well, I don't use it every day, so I don't use it. So even the frequency question has to be a little bit nuanced. But I think a starting point is just asking. And I don't think we're even there yet. But it's a valid question.
All right, thank you. And the last question we have is, as this does contain a cultural identity aspect, it could be seen as an attack on cultural identity to bring this up to people. How do you suggest we approach this to mitigate the defensive response?
Okay. It could be seen as, in my worldview, which is not the only worldview, if I say to somebody that eating curry is bad for your health, yes, that could be construed as an affront to culture, but it is a true scientific statement, right? Again, broadly speaking. But there are also competing cultural narratives, right? So my understanding as a Hindu and I know this is true, and Noor, correct me if I'm wrong, for Muslims is that we, based on our deities of importance, we are not allowed to knowingly do harm to our bodies as vessels. So on one hand, you have a cultural narrative that says, okay, sure, I can chew pan because it's part of my culture. On the other hand, I'm also defying another theoretically equally important cultural scripture. So the question is, okay, how do we offer sort of offsetting cultural narratives? Again, having parents who now have grandkids, in other words, my own children, I recognize that an important driver of my parents' behavior is to be around for their grandchildren, which may or may not have been true 15 years ago. So when I talk about framing risk, telling my parents that don't do this is bad for you as an individual may or may not hold anything. But now when we look at value propositions, we know that collectivist cultures, children, absolutely. Grandchildren, oh my God, yes, right? You will do anything for those folks. So there are counter narratives that are equally compelling from a cultural level. And I think we need to present those. And then the individual can say, yes, my right to chew pan is more important than my right to be around for my grandkids. Okay, you said it. We'll respect it.
All right, those are all the questions we had for today. And if you have more, please feel free to email us. Thank you again to our guest speakers, Dr. Tong and Dr. Mukherjee, for taking the time to be here and talk to us today. I would also like to thank our audience for joining us today in our tobacco webinar, as well as thank our wonderful guest speakers again for taking the time to assist us in spreading this information to our community. Thank you.